Dear colleagues, I'm Paolo Righini, Senior Consultant of Vascular and Endovascular Surgical Unit at Policlinico San Donato, directed by Professor Nano, and I'm the Principal Investigator of the VASC trial, the first clinical trial on the empty vein ablation technique for the treatment of great saphenous vein through an endovascular procedure with VELEX. Endovenous ablation technologies have become the standard of care for the treatment of great saphenous vein insufficiency. Definitely the thermal L2 machine technologies like radiofrequency and endovascular laser ablations have shown better results, especially in the long term, and with better results for the bigger diameter of great saphenous vein. But has some disadvantages like skin pigmentation and nerve injuries. On the other hand, non-thermal, non-2 machine technique like foam, direct or catheter-directed technique, mechanochemical ablations and channel-acrylate ablations have shown good results and better intraoperative patient comfort without needs of 2 machines and anesthesia, but lower better results in the vein diameter bigger than 7 or 8 millimeter and with some rate of reperfusions in mid and long-term results. So our technique, subject of the VASC trial, the empty vein ablations technique, is a novel endovascular technology with the potential of overcome at least some of the other technologies issues. Here is a brief animations to better understand the steps of the procedure.
It starts with a catheter being placed into the veins. Once the catheter is placed, the central balloon is inflated, moving blood laterally. Then external balloons are inflated in order to generate an empty closed vein system. Then the central balloon is slowly deflated and sclerosing agent is injected into the empty closed vein system. As a consequence, endothelial cells and muscular layer are destroyed, causing the occlusion of the vein segment. The catheter and the drug can now be moved safely along the vein to treat other segments. The central balloon is inflated back and the drug is pulled out at the end of the procedure. Now all balloons can be deflated and the catheter can be removed.
So EVA could have potential advantages over the other endovascular ablation techniques because a more gentle but controlled homogeneous ablations with virtual no limits on vein diameter would extend patients' indications. No thermal ablations means no needs of 2 machines or cold saline solutions and no local anesthesia, with a higher patient compliance and comfort during the procedure. But could have also advantages over sclerotherapy because EVA principle allows full control of agent contact parameter between drug and venous inner wall, meaning positions, concentrations, homogeneity, and durations of the procedure. And lower agent concentrations because there is no dilutions by the circulating blood, with the ability to treat vein of any diameter bigger than 10, 11, or 12 millimeter. And retrieval most of the sclerosant agent means a higher efficacy and a higher safety of the procedure. So the VASC clinical trial is an ongoing clinical trial conducted in 2 centers, the Policlinico San Donato, that is the coordinator center where I work, and Ospedale San Raffaele in Milan. We'll enroll at least 30 patients with indications of great saphenous vein diameter from 5 to 12 millimeter. Primary endpoints will be the occlusions of the vein postoperatively at 1, 3, and 6 months, and the safety of the catheter. Second endpoint will be the pain level intraoperatively measured at the end of the procedure and after 7 days from the intervention, and the quality of life that will be measured through Aberdeen varicose vein questionnaire given to the patients before the intervention at 3 months follow-up. Here are some procedural details and results of the VASC trial. Analyzing preliminary results of the VASC trial, we observe a clear tendency of the great saphenous vein maximum diameter to decrease over the time that seems to remain stable at the follow-up period now available, as well as complete closure of the treat vein, either for the first or the second part of the VASC trial so far performed. So, in conclusion, VASC trial preliminary results seem to confirm all positive expectations. Once statistically consolidated with adequate follow-up, they could confirm that EVA is a technology with several advantages and no obvious disadvantages with respect to the other endovascular procedure and can be considered a candidate to become a standard of care in the treatment of CVA.